Thank you again for coming out tonight. I'm really excited to get to share with you all some things that we're doing at APD, talk a little bit about the history of APD in emergency medicine in particular, talk about some things that we're doing, and talk about where we're going. And really appreciate the opportunity to talk to everybody here. I'm going to be speaking with a couple of my colleagues, Dr. Scott Rodi, who's an emergency physician, and is the interim section chief, regional director of emergency medicine. So we'll talk a little bit about some regional issues. And then Matt Babineau, who is an interim director of the emergency department at Alice Peck Day. And I think I mentioned, but not sure, I'm the chief medical officer, as Tracy said, at Alice Peck Day, and I'm also an emergency physician. So, and still practicing at Alice Peck Day. So, and we'll give you the opportunity to ask some questions at the end, but certainly as things come up, feel free to make this a conversation also. A little bit of history about emergency medicine, emergency care in the United States. The first emergency department was in Alexandria, Virginia in 1961. And that was moving from the concept of the emergency room, when we still all use, and we do also, the term ER, which used to be a room where a specialist or a consultant was called. And then as the concept of emergency care in improving emergency care evolved, 1966, the Federal Highway Safety Act set standards for ambulances and training in the US. Vietnam War set standards for trauma care, and the concept of stabilizing a patient in the field and bringing them to the MASH units and taking care of them and stabilizing them, showed that they could save lives doing that. And that's the model that basically evolved into emergency care and trauma care in the United States. And also that, another thing that happened with the Vietnam War was a lot of returning vets had medic experience and became some of the early paramedic force, EMS force in the United States. And then in 1972, the AMA, American Medical Association, recognized emergency medicine as a specialty. That was around the time when the residency programs were, Dr. Babineau, Dr. Rodi and I started. I was out in Hennepin and Minneapolis, and Dr. Rodi was out in California. So that is basically when the specialty of emergency medicine began, in recognizing that there were trained physicians who could be trained to handle really anything that's walking through the door and recognize anything that's walking through the door and be able to stabilize it. This is a little bit about what I spoke to already, is ER versus the ED and the concept of evolving to an emergency department. What we want to talk about tonight is what we're doing, improving the care, the already great care that exists at Alice Peck Day, and thinking about what we do at Alice Peck Day, what we do in relationship to Dartmouth, and the trauma center that we take advantage of at Dartmouth, the ED, the primary care clinic that is at Alice Peck Day. And one of the things that we want to talk about also is what the role is of the staffing model that we have at Alice Peck Day now, which is the Dartmouth emergency physicians, or staffing, helping staff the emergency department. In addition, there's a hospitalist team that's coming from Dartmouth. That, combined with the electronic medical record, is really opening up the possibilities for us to see all of the care that people are getting, whether it's at Dartmouth or Alice Peck Day, and help coordinate the care. And it's really, started in September, and has really been a lot of fun, and has really been a wonderful experience so far, I believe, for the patients and the community at Alice Peck Day. So I was going to ask Dr. Rodi, because he's in charge of the regional programs, to talk a little bit about the other advent innovation that we have at Alice Peck Day, which is teleemergency medicine, and using the expert resources we have at Dartmouth while caring for people at Alice Peck Day. So Scott, if you would be able to speak to that a little bit, where that is, what the work you've done on that.
So I think Michael's pointed out there are actually a number of points of coordination now between Dartmouth and APD that are possible, in part because we're sharing staff, in part because we share an electronic medical record. And then TeleEmergency is, I don't know if many of you are aware of it, but I'm sure you've heard of Telehealth in general, which is just using technology typically to convey health resources to a secondary setting. In the case of TeleEmergency, we have available, APD now has available to them 24/7 access to an ED-boarded, ED residency trained physician and an experienced ED nurse. We offer that service through Dartmouth during weekdays, and then we have another we have combined with a large outfit in the Midwest to provide coverage overnight. And hopefully it will help to augment the care. It should also help augment things like transfers and other sort of complexities related to care. It's even more helpful at smaller hospitals where some of our critical access hospitals there, unlike APD, don't have physicians working in their emergency departments. They have associate providers. And in that model, we are, I think, adding even greater augmentation.
Yeah. I was going to ask Dr. Babineau to speak to the question or the concept of when do you use an emergency department. We have a range of possibilities open to us, from urgent cares to great primary care that exists at Alice Peck Day. And actually, that's a question I'd like to see also. How many people get their primary care at Alice Peck Day or use Alice Peck Day for primary care? Great. Yeah, it's a wonderful. It's a wonderful primary care group, and I just feel so fortunate to be at a place where that is just a great quality care that exists there. And I should mention that I am just new to this community. I've started here in June, but I went to college up here and but I'm really excited to be here. So Dr. Babineau, would you mind speaking a little bit just to, kind of when you use an emergency department and kind of what you should be thinking when you say, do I need this service, which hopefully nobody needs.
Yeah, sure. Well, I think if you think the overall answer I'd say is if you think you're having an emergency, you should come to the emergency department, which seems a little, facile, but I think what we notice is, one thing is part of our training that I think I've always taken a lot of pride in is that we really sit at the nexus of the whole complicated healthcare system. So we sort of exist right between primary care, subspecialists, the clinic center, the referral centers. And so our job, especially at a place like Alice Peck Day, is if you think there might be something wrong, then you come in and see it. And, we might not be solving your, I have high blood pressure, I can't go to the emergency department and have someone get rid of my high blood pressure. But if I think I'm having a problem from that or something like that, our job is to really see, is there an emergency condition that needs treatment or stabilization or transfer or whatever. And one of the things that always surprises me is sometimes things that seem, really bad and really acute turn out to not be an emergency, and vice versa. We've just had recently someone who, comes in thinking they just have really bad, acid reflux, and it turns out they're having a large heart attack. And so the way I look at us doing our job in the best way is being able to see people 24/7, give you, we won't know you as well as your primary care, but I like to think we care about our patients just the same. And what we can do is sort of work through that acute problem with you, find out what's the safest thing to do right then. Now, some of you have been to the emergency department, know sometimes the answer is, I'm not sure, everything looks okay, let's have you follow up. But I think that's really part of the spectrum of health that we provide. I think specifically at Alice Peck Day right now, one of the things that we're proud to be sort of bringing on, and we've had a lot of support from the hospital, is without changing the culture of Alice Peck Day or doing anything like that, we're trying to bring some of the benefits so that if you, rather than bypassing us for Dartmouth-Hitchcock, if you come in, we can still see you. It's the physicians who know both centers and can kind of adequately triage, can we keep you here safely? Can we do everything here? And if not, how can we kind of stabilize things and get you transferred? So, yeah, I think that's about.
Yeah, I guess the other thing I was going to mention that we had talked about earlier, Matt, was just that we've also been working with Lebanon Fire and Harvard Fire is when to bring somebody to the emergency department at Alice Peck Day versus Dartmouth. And they do a really good job. This is what they do all day long, of figuring out what you need where. And if you have a critical critical care need, if you're having a massive stroke, if you're having what appears to be a heart attack and they are able to do EKGs in the field, or if you've had if you had a collapse and from an arrhythmia, they're going to know that and going to bring you to Dartmouth and get you the critical care needs you should. If you're somewhat look relatively stable and you can have a pneumonia, or if you have abdominal pain and it might be an appendicitis and needs to be worked up, APD is going to be a great place to have that done. You have the team, you have the resources to work that up. But that sort of gets to the point of, if you think that you are critically ill, please don't drive yourself. A lot of us in this room have been in emergency medicine for a long time. We see a lot of bad cases where people say, I'll just bring myself. So if you're critically ill, that's what 911's for. If you are wondering, I'm feeling very sick, I have pneumonia, I have abdominal pain, I want to know what it is, those things are going to be really great cases to come to APD, especially if you're in the community and that's where you get your primary care. And a lot of these other things we talked about are going to be resources where we can coordinate your care, call upon the expertise at Dartmouth when we need to, use TeleEmergency medicine when we need to. So, and we have this open electronic medical record now where we can have great visibility to where you are and communicate. But just looking at this list, this is not a clear list for APD, but this is a list of things that you would think about if you're having difficulty breathing, chest pain, severe headache, open fractures. If you fell and you've got a sprained wrist, then maybe that's a good case for an urgent care. But if you have a deformity and it needs to be reduced, then you need to be in an emergency department, and something that we definitely can take care of at APD. Pediatrics, in addition, on this list, we really, I personally love taking care of kids, and pediatric care is something we definitely can and want to be doing. APD's emergency department, we're obviously open 24 hours a day, 7 days a week, and patients typically receive care within 14 minutes. That's because we're a lower volume place compared to Dartmouth, which is taking in patients from all over the state. We've all worked in really big, busy emergency departments, and then Dr. Rodi's worked in a couple of the other kind of critical access or smaller hospitals in the area, and it's different. It's not a promise, but sometimes you'll get seen more quickly, and again, we have the resources to take care of most emergency needs that you would want to seek care for. Nice quote from a happy customer. Not everybody's happy when they leave the emergency department, but everybody knows in this room where Alice Peck Day is. I think, is there anybody who doesn't know where it is? Give me directions. So that's really what we wanted to talk about. I kind of just to sort of summarize. This is a different, newer staffing model. Before it was the hospitalist and ED was a corporation that was staffing the department. So we're bringing in the DH team to really augment the really high quality care that's already occurring at APD, and building on the communication that we have with the electronic medical record, and really working to do more and take care of a higher level of care in the emergency department. And so that's it. I would love to open this up for questions, because I'm sure people do have some questions, and I'm going to start with you. Are you going to tell us your story?
Do you have a hospitalist here?
Thank you for asking. We do, and
what's his role? That's my question.
yeah, it's a great question. So let me explain what a hospitalist is, and then talk about what the role is with the Dartmouth hospitalist team and the emergency medicine team and how we work together. Hospitalist role, and was going to ask if Beth could come, but she's at, one of our colleagues, Dr. Cook, is at Alice Peck Day tonight. Really developed probably 10 or 15 years ago, and as a field, as a specialty, are largely internal medicine trained, but also some, probably another 30 or 40%, so majority internal medicine, but another good portion of that is family practice. And their role is to be always present in the hospital to take care of anybody who's coming in from the emergency department, admitted directly from the office, having, speaking with some of my gray-haired wisdom, and there's a great quote I have from a friend who said, "Wisdom is what you get right after you needed it." And so that's why I have so much gray hair, I think. But we practice in both models where we had, I was at Concord for a long time, Concord Hospital, and a really wonderful group of primary care physicians that we would all get to know and work with, but we were managing a lot by the phone, and they were seeing the patients in their busy schedules at the end of the day, and depending on the person, were sometimes more or less available at night for a call. And this is a very focused model of care in the hospital so that all needs are met all the time. And it's, I think, and I've seen this transition, and Dr. Rodi, I think, can speak to this too, and that I think there was a loss of that feeling of what it was like to have your doctor come in and see you after they saw you in the office, and I think that certainly that is a loss, the personal relationship of that person who's in front of you. But in terms of the timeliness and the quality of care, I think it's been better for patients overall in what I've seen in working in both worlds. The hospitalist team here at Alice Peck Day is the Dartmouth team. They're all internal medicine physicians. And I think one of the benefits that we've already really seen is a lot of communication between the emergency physician team, the hospitalist team, both at Alice Peck Day and across the system. So that somebody needs, just last night, this is a great example, I had a gentleman who came in who was, had become pretty sick pretty quickly with fevers and chills, and it was called sepsis, maybe a bloodstream infection in a kind of an unusual infection that was really, he came to the right place at Alice Peck Day, APD. We had the right antibiotics going, and he was looking better. Was admitted to the medical floor at APD, and then during the night started to get sicker. And the hospitalist who was there at 3 a.m. Was talking to their colleague at Dartmouth and saying, I think we need more. And he was admitted directly to the floor with communication was very open in the electronic medical record in those two individuals, and the patient went to Dartmouth where he is right now. And that's just a good example of how the care is going to be coordinated, and I think really high quality care. So it won't be, have kind of gaps in communication that used to exist. So that was a long answer to the hospitalist question. I don't know if that is what you're looking for.
But does that preclude then at some point you seeing your own doctor that you've seen for 25 years or 30 years?
Yeah, it doesn't preclude it. It depends on the individual. For one of the patients that I saw yesterday, that physician had sent in the patient and was going to come by and see the individual later in the evening when the office was done. And some people still do that, and it's welcomed. It's not certainly not excluded from seeing their patients in the hospital. Yeah.
So does the hospitalist contact your doctor to find out your history when you're admitted?
Yes. Now, if it's not in the electronic medical record and not as available, which it is for a majority of patients now, and that would involve calling the primary care physician. But yeah, they would get records and history. That's one of the benefits in the era we're living and practicing, because we, I know Dr. Rodi remembers this. I'm excluding you from this. If you don't mind being too old here, but I get stacks of records that you had to work through and find, literally that tall sometimes. So yes, and that's in anybody who's outside the system is going to be using an electronic medical record and have great summaries that they can send.
We live probably 5 minutes from APD.
Yeah.
Closer than the fire station. So I guess if one of us should have an emergency and the other one is capable of driving and still help.
Yeah.
Should we just, one drive the other? I mean, there's different cases.
Yeah.
Of course, but I mean,
That's such a good question. And, I have, driven family members who are sick, who, I have a different background than you, but, I've also probably made the bad decision and driven somebody before when I shouldn't have. But I think as a general rule, things that you shouldn't get driven to the hospital for, or if you think you're having a stroke, if you think you're having a heart attack, you're having severe chest pain, you're sweaty, you're nausea, you're dizziness, you have arm pain with it, classically chest heaviness, sweatiness, nausea, left arm pain typically, though it can be the other arm. And then, and you can help me out here, is a lot of the teaching that we're doing now in the communities is recognizing a big stroke, it's face, arm, speech, and yeah. What?
Face for speech and PT is for
Time, yeah. So meaning it's a timely intervention. And the stroke care has evolved or changed a great deal in the last decade, where we're starting to give clot-busting medications that can break up a stroke and improve your outcomes or stop a stroke, and then even beyond that, interventions to try to remove the clot. So there are good reasons to go, to call 911 and have the professionals really decide what you're having and where to go, because, like I said, they're really good. They do a great job of making those decisions. But if you say, geez, I've had this heartburn for several days, and I'm stable, I'm fine, I'm walking around, and wondering if I have a abdominal pain that I need to get figured out, or you're not feeling dizzy or weak, then, or you've been coughing for 3 days, you might have you think, geez, I'm finally coming down with a pneumonia. Then certainly you would want to drive. You can drive yourself. I think it comes down to some of it's just common sense. If you feel like I'm having a life-threatening illness, truly, then you shouldn't be driving. So let's get there quickly. You should call 911.
It's really about time to first medical contact, and we're really lucky with LEB EMS are really, really good. So if you calculate the time till they get to you, they're going to already start doing all of the things that we would be doing anyways.
Great point.
And it would be a safe way to do it. So, again, we're very lucky to have them around.
That's a great point. Yeah, they can do an EKG when they arrive at your house and send it to the emergency department and have them look at it. They can start medications en route. They can really get the team ready to take you right to the catheterization lab if that's where you need to go, and that's what they're seeing. So yeah, that's a good point. Really accelerates not just transport but treatment.
Can you request where you want to go? We're about 35 miles out of here.
Yeah.
And because of the very positive experience that she had here
Nice.
a couple of years ago.
Nice. Great.
I don't want to go to
Yeah.
the hospital next door. I'd really like to go here.
Yeah.
Is that within the realm of possibility?
Yeah, and we've got some other emergency medicine people with emergency medicine expertise in the room who also can answer. But I don't know, Scott, do you want to take a shot at
The
that?
general rule, yes, you can certainly request it, obviously. The general rule is that if you're medically stable, the most, and the ambulance rig doesn't have to go too far out of their local district, if they're not leaving their local customer base unattended to, they will usually be willing to do that. If you're not medically stable and they feel like it's a bad medical decision to take you to your preferred hospital, which is 35 miles further than the nearest hospital, then they may not go along with that request. But if you're medically stable and there's not some other extenuating reason, they will usually try to honor that request.
The insurances don't have any impact on those decisions?
Not that I've ever heard of.
Not from that transport.
I don't think
yeah.
that's an issue.
That's a good answer. Much better than I could have said it. Thanks, Scott. Yeah. Yes, sir.
I go to the VA, but I don't
Yeah.
have good insurance. I can go anywhere.
Yeah.
And I've been to all three, actually.
Yeah.
And so I happen to know that there's no doctor in the house necessarily on the weekends or in the evenings. And so for me, that would be a part of my decision is
Going
how
to the
long it's
VA,
gonna
yeah.
take,
Yeah.
or if I go over there, are they
Yep.
going to send me over there?
Yep. Yeah. Yeah, the VA is a great resource, and we're a really wonderful place to be for the right things. But I think
The emergency department isn't that, I mean, it's always busy, it seems, but
Right.
we've, had experiences with relatives that,
Yeah.
On a weekend and at nights, it's not covered as
Yeah.
well as perhaps you would dark.
Yeah, another, that brings to mind, another piece of this conversation that's really important is, if you've had something that's not, you don't feel like you're in the moment, having a life-threatening illness, your primary care physician can really help with this decision, and the person who's on call also, because they will be able to look in your records and really very quickly kind of see your history, your medications. And so that's a great resource when you're trying to decide, because so do you have a primary care physician?
Yes.
Okay, so that person would know you, or the person who's on call look in the electronic medical record and say, I think these are the things I'm thinking about, and I think APD would be a great place, or you sound critically ill, or this is at the right hours, like you said, when there's coverage. I think you've gotten a lot of your care at the VA, and that this would be appropriate for you to go there. I think they'll make a lot of really good decisions on the phone if you have time to talk to them and involve them.
We have the ability to assign for having our records available to get us.
Right. Yes. Yeah. And I've always found the VA records are really, they're not fancy to look at, but they have it all there. Yeah, they're really great in terms of medications and history, and they're always really been great about sending them over. So
Basically, if you have an emergency, if your spouse has an emergency, and it's one of the bad emergencies, the life-threatening.
yeah,
Like, who knows how long, I call 911.
yeah, yes,
And if it's one of the in-between, which usually it is,
right.
you just have to kind of decide between what you know and
Yep. And the really hard part of this too is, like Dr. Babineau said, some things that seem minor can be very serious and be a heart attack, and something that looks really bad in the moment might not be as serious. So it's hard to know sometimes, and that's why Congress passed the prudent layperson law, which you were able to choose or decide when you're having an emergency and seeking medical care, and that still covers a lot of issues around insurance. So.
Is that list available? If you have a list of different things that you should consider?
Yeah, sure. Yeah, that's, I don't know, Kelly.
Yeah, we'll make it public with the video afterwards.
Yeah.
I'd say one thing too, if it applies to anyone, is one of the things that, in the emergency department, we take care of anyone, no matter, we don't, like, whether they have insurance, whether they don't have insurance, we are sort of ethically and legally and everything, and the reason lots of us go into it is to just kind of do what we can for the patient at that time, and lots of times, yeah, that's imperfect, but if you know anyone who you can spread the word to, we don't want anyone to sit at home getting sicker rather than coming in to see us when we can try to help them,
Thanks.
For sure.
Yes.
Are you trying to get the word out that APD now has an emergency department that's 24/7?
That's
Because I would think
Mhm.
my choice, if it's 14 or 15 minutes, as opposed to 4 or 6 hours
Yeah.
at Dartmouth,
Yep.
I will always come to APD because I know there are good physicians here.
Yeah, and it's the
So when
same.
the word gets out, Dr. Lynch,
Yeah.
you're going to be swamped.
Yeah. Hopefully, I think that would be the right, best for patients. Again, because you have both, the teams working in both places, and communicating well, and will be able to coordinate your care, and so yeah, that's definitely what we're working to do, to really, again, augment and improve the already wonderful care that's delivered at APD. Yeah.
I will add from the Dartmouth, this is sort of, to me, seems like one of those sort of rare win-wins, when hopefully it's best for everyone. I think this is a great thing for patients. This should be a great thing for APD and their ability to see more patients and deliver more care. And to your point about the long waits at Dartmouth, one of our hopes also is that as APD sees more patients and we are seeing fewer patients, maybe our wait times will not be 4 hours. So hopefully this is, eventually we reach a steady state where everybody is happier. We'll see.
Very
Yeah.
smart.
I would say too,
Yeah,
yeah,
that's-
I mean, because now the ED team and the inpatient hospitalist team, we work at both sites. One of the things that, I mean, I had a case when I was working at APD a couple of weeks ago, and it was sort of perfect APD, like quintessential, the goodness. I was text messaging with the patient's primary care at 8 p.m. on a Saturday, trying to figure out what to do, and also talking to the hospitalist, because the patient who I knew from Dartmouth, and the patient really wanted to stay at APD, and we were trying to kind of talk about, can we, safely keep this patient here, or is it really going to be safe to go there? And because, all of the doctors, whether you're in the ED or the inpatient, kind of know both hospitals, it just gives us a lot of sort of added flexibility to kind of, do what patients want as long as it's safe for them, So it was a really cool experience.
You guys sound too good to be true.
Well, it's the ER too. I mean, I had to say the ER is a great place to work and everyone works really well, but it's an imperfect set. It fills a need imperfectly, right? My wife, when she had to go a couple years ago, I had to say hey, you're going there, you're going to sit there for 6 hours to see the doctor for you know what I mean? And so it's not perfect. I do like actually working a lot at APD because I find that I get to spend a lot more time talking with, just because it's not busy right now. So I can spend, 30 minutes just chatting and, talking through things. And when I'm working, up the hill, I have to kind of just be running from room to room,
Yeah. We recognize in healthcare that we haven't been historically great about communication, and we have siloed or fractured systems, and communication has been really hard, and it has been fun to see it evolve and get better. I think we're always trying to get better. I would say, kind of back up to a prior comment, we've all worked in very busy emergency departments, including Dartmouth and other places, and other people in the room have done the same. And it never makes any of us happy in the emergency department to see people waiting. It's our goal to see everybody in a timely manner, and it's hard and frustrating. And it's always the improvement work to improve the wait times and deliver the best care. And this is part of what we're doing here. As you had mentioned, is trying to get people to the right place and a different place to expand the care we're able to give. Has a different staffing model, and the electronic medical record helped address the problem of the opioid epidemic. Is that a good summary? I think any of us here can answer that. Maybe a couple of us should, but I think the answer to that's yes. It's been helpful on a number of levels. I think we in emergency medicine really saw the problem when it started, and not that we weren't a part of it, but we were working to say, we need to reduce fewer opiates and prescribe just what you need. And there are checks in places now that are a little burdensome. When they first came out, they felt very burdensome, but I think have really improved through the electronic medical record, where we have to document that somebody's getting an opiate prescription, why they're getting it, look and see if they've had other history that wasn't disclosed to, or unaware of it, that might affect our prescribing. And I think there's a really great awareness now in healthcare settings like Dartmouth and APD that we need to be very careful with opiate prescriptions. It was, I think we all have seen in the news and understand now what happened. It is really, really tragic, and continues to be a tragic problem, as, with the kind of the growth in heroin use. But I think in terms of prescription pills and our doing a better job than we were a decade ago, I think the answer is definitely yes.
I would say too, the whole focus, even in my younger career, there's been like a big change from even when I was starting. Like it was always kind of like a game of cat and mouse. Like you were trying to, as the doctor, trying to like figure out who was trying to get opioids and like kind of pulling your leg, and then you'd find them out. It's very easy now. We have all these databases that we can query to see how many pills they've gotten over the last year. And secondly, I think more importantly, the focus has really changed. So rather than that kind of punitive, aha, I got you, we're actually, the emergency medicine writ large is sort of at the forefront of starting people on this medication-assisted therapy for opiates. So you need a special kind of drug license to be able to prescribe that. And both at APD and at DHMC, we've kind of worked on and are continuing to work on, identifying those people and then getting them medication and then all the other types of treatment that are associated, including some, local residential places and stuff like that. So it's felt a lot better as a doctor to be able to help people who you see doing that rather than just, call them out. It makes those interactions so much more satisfying when you can help someone rather than, scold them.
No, it's a long, complicated
Yeah.
story, but I think we felt when we were practicing this isn't right, and there was something really going wrong here. And I think if you've seen the 60 Minutes reports or those kind of things, what pharmaceutical companies did really bringing a lot of these medications inappropriately to communities is really clear. It's the question is now how do we recover, and I think we're doing a really good job of thinking about that. And it's also a different relationship with the patients now. It's not punitive. It's how can we help you, and I think. Back to your point. So
What
last
other
question, yes.
departments do you have that are available to you at 3 o'clock in the morning, such as CAT scans,
Yeah.
radiology, lab?
It's such a great question. Thank you for asking it. So CAT scan is available 24/7. The ultrasound is not, though we in emergency medicine are trained to do ultrasounds, and we do a lot. We're not radiologists, and we're not as good as the ultrasound techs, who are very, very good, but we can see and do a lot of things now with ultrasound ourselves, and we have an ultrasound machine which just came to APD last week that we can do and use and sort of help us with decision making. Sometimes you'll still need to get a formal ultrasound study, or often, just to confirm what we're seeing. But that's a great tool for us, and labs available 24/7, and there are some the minority of tests are sent up to Dartmouth on a courier system, but all of the tests you need for emergency department diagnosis are there, and services. That sort of gets into the call question and what specialties you have, and again, I think that's our job is to figure out. Is something stable? Can we do it? Do you need to see a specialist? And then working with the expertise we have up the road at Dartmouth to really tap into that great resource. Thinking more about the inpatient side and sort of the platform that you've been working on developing, they're going to be doing consults starting out with cardiology, gastroenterology, infectious disease. Infectious disease, so that you will, again, have an EMR where everybody's is able to see what you have or what the working diagnosis is, and one of our hospitalist colleagues will call and say to infectious disease, here's the picture I'm looking at. What do you think about my antibiotics? Also plugs you into close follow-up with a specialist if you need it. I think that's going to continue to evolve.
Yeah, and that's it's not. I think it's going to be a great service. It's not 24/7. It's not really an ED-based service. It's a hospital-based service.
Yeah.
But the hope is that rather than getting if you get admitted to APD with a modestly complex question, rather than just transfer you to Dartmouth to see the infectious disease doc, you can actually have that consult at the bedside. So and that's just getting rolled out. And APD is one of the pilot sites for that.
Yeah.
If you determine that, say, someone has appendicitis and needs emergency surgery, can you provide that, like in the middle of the night?
Yeah. Another really great question. Harder to answer than that one. So we work with the Dartmouth surgeons and general surgeons at APD. We are actively working on increasing our general surgery coverage because it's an important need. Dr. Rodi's been working on some regional coverage too with general surgeons. With New London, Mount Scottney, so that's something that we're talking about. But again, if you have a surgical problem that we diagnose, the surgical team at Dartmouth is, talking to the same team, and it's really an easy. Yeah. I had somebody with a a ruptured appendicitis, at 7 o'clock, a few weeks ago, and talked to the general surgeon, and took the patient to the OR from APD. Yeah. Yeah, thank you. Well, thank you everybody so much for coming out. It was really great talking. Yeah, thanks for a great talk.